So why MCL? Okay, for your information, MCL is the second most common injured ligament in the knee after ACL. MCL has excellent healing capacity. If you compare with ACL and PCL, it has the best healing capacity of all. Most surgeons opted for conservative management. However, the literature on MCL rehabilitation is still limited. People keep discussing on ACL, PCL, but the chances of healing of torn ACL is lesser compared to MCL. That's why I choose this topic. So the incidence of injuries in MCL is around 0.24 to 7.3 per thousand people, with male predominant than female with 2-to-1 ratio, and the most common sports injury is in contact and powerlifting sports. So let's dive into the anatomy of the MCL. So if you look into this side, the green color is your superficial MCL and the purple color is your deep MCL. So it has two main fibers. So the superficial MCL originate from the femoral attachment at the medial femoral condyle. It runs medially, extrasynovial, extracapsular, and it has two distal insertions. One is at the proximal part here, 4 cm below the joint line, and it blends in with your semi-membranous attachment. And another one is the distal insertion, as far as 12 cm below the joint line, distal to the breast answering. Each of these fibers has their own function, so I will discuss in detail after this. Whereas the deep fibers attaches again from the medial femoral condyle, and it blends in with the capsule of the knee joint, as well as it has an attachment to the meniscus, meniscofemoral and meniscotibial ligament, and it actually causes meniscus, your medial meniscus, to be rigid, and it provides stability to your the knee joint. So again, okay, like I said, MCL has two important attachments. One is at the proximal part, 4 cm below the joint line. Another one is the distal attachment. So another important thing that you have to know is the posteromedial structure. So when you talk about posteromedial corner, PMC, you need to remember 5 things. The POL, posterior oblique ligament. OPL, oblique popliteal ligament. Number 3 is your posterior joint capsule, posteromedial medial meniscus, as well as the dynamic stabilizer, the semi-membranous and its expansion, the pars tibialis and also pars reflexa. So the most important ligament in the posterior medial corner is your POL, according to the Lapratt and colleague in 2012. POL is the most important for valgus and rotatory stability. Thus, if you have MCL, you need to look into the POL injury as well. So since it is most important, let's take a look into the anatomy. It attaches from the medial femoral condyle, but it is at the posterior. So this is your MCL. Okay, it is at the posterior here. Okay, and it runs oblique, and it has 3 attachments. Number 1 is the superficial extension that attaches with semi-membranous tendon. The central extension that attaches into your posteromedial meniscus, and the most important extension or attachment is your capsular extension, where it blends in with your capsule of the knee as well as your oblique popliteal ligament. So this is very important because we need to see this in your MRI after this. Okay. So the function of MCL, like I said, it has 3 important fibers. The superficial MCL, the proximal part, actually resists valgus force in all degrees. Meaning, if you perform the valgus stress test, the one that is functioning is your superficial MCL. Whereas your superficial MCL distal insertion actually stabilize the knee in external rotation at 30-degree knee flexion, and your deep MCL actually stabilize the knee in internal rotation and in extension. It also has a lot of free nerve ending, Ruffini, Pacini, Golgi tendon organ, and it acts as the proprioceptive mechanism of the knee joint. Whereas the POL has the main function is the anteromedial rotatory stability. It also provides a static resistance to the valgus load when the knee in full extension. small role in prevention of the posterior translation, but the main function is by the PCL. And during the side step, it is important for valgus stability, especially wide action synergistically with your semimembranosus, and it prevents excessive external rotation and internal rotation of the tibia, internal rotation of the femur. Because of the attachment is quite oblique, so that is the function of the POL. So So why I said MCL has the best healing properties is because of these three important factors. One is the epiligament theory, which will be explained after this. Lack of synovial fluid. If you know, synovial fluid has a lot of anti-inflammatory regulators. So when you give HA, okay, because they have the anti-inflammatory properties, that is why you give HA. But the anti-inflammatory properties is not good for the healing. So MCL is extra synovial, extra capsular, so it has lack of synovial fluid, so it has enhanced capacity for healing. And because of the presence of epiligament, it has high expression of type 1, type 3 and type 5 collagen, which is important for your ligament healing. So what is epiligament? Epiligament is the covering of the ligament, same like your tendon sheet, your epineurium. So it is a covering of the structure, so in ligament is called epiligament. So in any covering, it has rich in fibroblast, fibrocyte and also blood vessel. And during the ligament injury, it acts as a main donor cell and blood vessel during the ligament healing. Because of high abundance of fibroblasts, it has high capacity to produce type 3 and type 5 collagen. And according to the study in 2020 by Georgiev, they found out that epiligament is more commonly seen in MCL as compared to ACL. So that is why MCL has the better healing capacity compared to ACL. So 2022. Tapi actually they have studied this for a long time, but it's published in 2022 lah when they compare MCL and ACL. If you look into the ligament healing, this is the only paper that describes the ligament healing. Okay, usually we learn about tendon healing, muscle healing, but let's learn about ligament healing. So interestingly, they took the MCL of a rabbit. So they studied the MCL healing, ligament healing on the MCL because of the best healing capacities. So what they do is they cut the MCL of the rabbit and they look into molecular level of the process of the healing. So there are three phases. One is the inflammatory phases. Initially there is vasodilatation, and then there is recruitment of the inflammatory cells by neutrophil initially, and then substituted by macrophages. And then in the pro-regenerative macrophages, it stimulates all the factors that stimulate the healing, the VEGF, proliferation of the fibroblasts, secretion of the collagen, which is especially type 3 collagen. And this can last from day 3 to day 21. So at day 21 to day 14, in between that, the remodeling takes place, whereby there is apoptosis of the fibroblasts and there is formation of the new ligament cells, and the remodeling takes place where the replacement of type 3 collagen is replaced by type 1. So the study is only up to 28 days and they predict the remodeling process occurs months to years. So this is the ligament healing of the MCL. POL tear. Isolated POL tear is very rare. 99% of the cases are associated with grade 3 MCL. The 78% of cases has concomitant meniscus and cruciate ligament injuries because of the high impact or high impact injuries in the knee. So Sims et al. Actually look into the incidence and prevalence of the POL tear, and most common tear is at the capsular arm. So if you remember, there are three extension: the superficial, central, and also capsular. So there is most common is the tear at the capsular arm of the semimembranosus, along with the 30% at peripheral meniscus detachment, and 90% has disruption of the semimembranosus and peripheral meniscus detachment. And most importantly, all the patients with grade 3 MCL, 99% has POL injuries. Meaning to say that if you have grade 3 MCL you must look hard for the POL injuries because sometimes you need reconstruction of the POL surgery.
Itu dia putus habis lah.
Hah?
Dilated itu means dia
Putus habis.
So yang tadi yang rabbit tu yang dia orang cut, dia cut half kan dia kata
Habis.
cut habis. So maksudnya dia sambung balik kan ligament.
Yes.
So kalau macam let's say kalau ACL dia partial tear, so meaning dia yang tempat yang dah putus tu kan, yang partial tak dia retain, dia akan sambung balik tu tak sambung. Itu tak sambung lah, maksudnya dia tak ada regenerative punya proses kan.
It's because of the synovial fluid. Okay, it has an anti-inflammatory, so the recovery of the ACL is lesser compared to the MCL.
Another thing, I feel that if in case of, because this question has also always played in my mind, why is it that MCL always tends to reattach, whereas ACL doesn't? But that probably is explained by the function of the function and the tension that runs through the particular ligament itself. You see, there is there is already some amount of tension within the ACL that when it ruptures, so to speak, it's very difficult for it to sort of reattach because the distals, the angulation at which it reattaches, and there is already a very tension in there. But MCL on the other hand, of course the fact that it is extra synovial is a big plus, but the other fact that it's always in contact, probably, I don't know. Because that question has always been there. Because when patient asks me, I'm not sure. Because patients tend to think that we are scamming them and they're telling you have to do the ACL. You know, how doktor macam mana benda lain tulang boleh lekat, kenapa ni tak boleh lekat? You can question yourself. So maybe this is one of the reasons why.
So history taking of MCL, the most important thing is we need to find out what is the mechanism of injury. In Brunei and Han, they mention contact injury, direct blow to the lateral knee causing the forceful valgus knee is the most common cause of MCL. But in my little experience, I believe the non-contact twisting is one of the most common, and it is commonly associated with the ACL and also meniscus injury. But I don't know. I never rarely see direct blow and contact experience. In my little experience in the clinic.
On experience.
History taking of POL is a bit different. So because POL is taught in knee extension, so valgus knee loading in knee extension is one of the mechanism of injuries, or forceful tibial external rotation, or a combination of both can be over the mechanism of injury. Especially they mentioned in the ski, when you fall from the ski, this is one of the mechanism of injury. Other history taken that is important is the onset of swelling. If you have acute onset within 1 to 2 hours, you should suspect ligamentous injury. If it is delayed, then you should suspect osteochondral, meniscus injury. A pop sound suggestive of more like a ligamentous avulsion injury. But inability to ambulate suggestive of severe injury in the knee. Associated with dislocation, especially knee dislocation, suggestive that there is multiligamentous injury. Locking. It can be locking or pseudo-locking.
In the knee dislocation, an MCL tear is the least of concern.
Yes. MCL tear is the least of concern. PCL, ACL. And then the instability lah. The most common instability reported is medial lateral instability, where you need to do pivoting muscle cutting in isolated MCL. Physical examination, well, valgus stress test at 30 degree is still gold standard, where you ask the patient to lie supine, flex in 30 degree, foot in neutral where your second metatarsal should face upward, and hamstring is relaxed. One hand is placed at the medial side, one hand is placed at the ankle, and you perform the valgus stress test. It has sensitivity of 86 to 96%. And this is the grading by the Malanga. If you have pain without laxity, is grade 1. Firm endpoint grade 2, and loose endpoint is grade 3. To assess the posteromedial corner structure, valgus stress test in knee extension can be done because the POL is taught in extension. So you do valgus stress test in extension. However, if you have cruciate ligament tears such as ACL, PCL, it can give false positive results. So the second test that you can perform is the SLOCUM test, or you perform the anterior drawer test in ER 15 degree external rotation to test the anteromedial rotatory stability. Same to ADT, but you actually put the tibia in the external rotation 15 degree. and you see the translation of the medial condyle. This because the MCL will not be taught at the external rotation. So if you have taught POL, so you won't have this laxity. But if you have taught posteromedial condyle, most commonly is POL, so you can get this laxity. So that is the significance of the SLOCUM anterior test. So in any cases, you need to perform a basic investigation. So plain radiograph is important. So you need to perform plain radiograph, knee, AP, lateral and merchant view. And what you want to look for is the occult fracture, such as tibial plateau fracture, second fracture, pelaginistatal lesion or loose bodies.
Stop. Somebody tell me what is Sigon's fracture. What's Sigon's? Proximal.
AL, so there is a disruption of the AL ligament, which also often associated with your ACL injury.
Second
fracture.
Okay, what about pelaginistatal?
So pelaginistatal,
Pelagrini, right? Not Gini.
Pelagrini.
Pelagrini ya.
Di mana Kelantan kan?
So pelaginistatal is a chronic MCL tear where there is calcification at the proximal insertion of the MCL. So you can see the calcification of the MCL.
You all are expected to know all these things, right? What is occult fracture?
So occult fracture is a fracture that is not obviously seen in the X-ray by non-trained eye. So occult fracture is often missed. So what we have to look for is to look hard for the fracture if there is any injury to the knee. Okay, for stress radiograph, not commonly done, but it is actually recommended for surgeon to perform this AP stress view in OT to look for other associated ligamentous injuries in patient who does not have any MRI. It has a high specificity up to 86 to 100% with positive predictive value of 100%. Meaning that if you do that, confirm it is MCL, positive predictive value. So this is the grading. And
how do you do that? I mean,
How do you do that?
You say just now.
so what you do is you take an eye, okay, and then you perform fiber stress test at 30 degree, and then you
Manually.
and then you take you shoot during the operation theatre. It is done commonly in OT and research.
But itu radiograph, X-ray film.
You mentioned that stress radiograph, right?
Stress radiograph. So what you do is
with eye.
with eye. So you do in OT. OT kan ada X-ray kan.
But in radiographer also can do.
Radiographer can do, yes, tapi not commonly done.
Yeah, SKL dia ada buat.
Ada buat?
Tapi dia ada guna one device to produce, bukan manually. There's one device to actually produce.
Oh, bagus lah.
Really?
Yeah. Terus mana?
Untuk ACL tu.
Untuk ini even ACL dia buat stress.
Stress test kan, because they want to look into the
There's one
MCL.
device. If I'm not mistaken, Talos device. Mistaken lah. So memang ada one device, dia akan bagi macam fulcrum and force.
Yes, yes.
So dia bukan ada orang shoot kan. Ada one device yang.
Ada one device lah.
Oh, that's good.
Kita kena beli satu lah pasal center kan.
Yeah.
Okay, so anybody knows what is this in the left side? Yeah, this is how you look lah. Pelaginistatal, so classification of the proximal or femoral attachment of the MCL, suggestive of chronic MCL tear previously.
What is that X-ray? What does it show? The one on the left? The X-ray dah cukup besar.
On the left, I think
Subchondral ni
That's chlorosis.
Oh, left. Oh,
avulsion fracture
Avulsion fracture or what?
of the MCL.
No, it's not.
Medial
Can you
femoral
tell
condyle.
answer?
Pelaginistatal.
That's the one.
classification.
Classification of
MCL.
That's the one, the gambar macam.
So this is the occult fracture. So if you look into this, that's why they say occult fracture, because in the non-trained eye, it can be normal. Okay, but you can see that there is increase in your tibial plateau, and then this is the
Increase in tibial plateau.
Brush. The lateral, right?
yeah. So you have to look hard for the occult fracture in patient who has.
Maksudnya yang lateral side tu
Dia terangkat sikit. Okay. So that is the meaning of occult fracture. MSK ultrasound, well, commonly done by us sport physician, but not commonly used by the surgeon. It has sensitivity very high, 93 to 94%, because it is a superficial structure, and specificity up to 83 to 96%. However, sadly, report by Mayer, it is specific, real time and widely available, but actually ada ayat lagi bawah tu, not commonly used in clinical practice.
And it is
Operator dependent.
Can you see? Can you see? I cannot see.
Okay, so this is MCL. So you can see the joint line here. This is your joint capsule, the MCL, and then this is the
by the MCL should be the extra capsular, the superficial leg,
apa dia?
and the XRAY.
Dia memang extra capsular, extra
Superficial
cellular.
lah.
This is also extra capsular, extra synovial. Okay, and this is your medial meniscus. Besar hati bini. POL ultrasound, not commonly described in the literature, but there is some sport surgeon describe it by tracing the MCL at the proximal insertion, and then you rotate it a bit oblique, okay, like this, and then you can see there is one ligament here, and this is actually your POL, and this is your MCL. But it's not commonly described, so maybe we can practice it in the clinic lah, kalau kita sempat.
Tengok MCL tu. Ni saya nak pergi.
Practice lah yang ni.
Oh, ada mesin yang bagus sikit.
So the surgeon always said that MRI is always the best because they do not know how to use ultrasound. But the sensitivity of MRI is as low as 7% and specificity is 40%. The diagnostic arthroscope is still the gold standard. However, we should not put MRI as one of the main modalities, because sometimes in MRI they cannot see a very small tear or chronic tear. So MRI has less sensitivity and specificity in mild cases. If you have a grade 3 MCL, grade 2 MCL, yes, MRI is very good in detecting that, or deeper organs such as ACL and also PCL.
But
So-
I said the anesthescope is an extra articular
Extraarticular, but you can see.
going from the inside.
So if you have an MRI, so what you want to look for is at the coronal and axial view. So you want to look for in T2 images the hyperintensity lesion of the MCL along with the tissue edema. So in grade 1 you have intact MCL, but there is high intensity signal in surrounding tissue. Grade 2 you can have this partially disruption of the MCL, and grade 3 is complete MCL disruption. So if you look into this T2 image coronal view, so this is your MCL. So you can see that there is intermediate signal around this soft tissue, but the MCL appears intact and appears thin. So we can conclude that this is a grade 1 MCL tear. However, if you look into this area, you can see that this is your MCL, and this area high intensity signal, and there is partially disruption of the MCL, superficial, and deep also has some disruption. So we can conclude that the patient has partial disruption or grade 2 MCL, superficial and deep. In this view, you can see there is extrusion of the meniscus, the deep MCL is gone, and then the superficial MCL there is disruption with high intensity signal, suggesting that there is tear at the femoral insertion of the MCL superficial fibers and also deep fibers. The meniscus maybe ada some injury juga lah. Sometimes you can have STENER-like lesion. STENER lesion is not only seen in the thumb, but it can be seen in the knee as well, where there is avulsion of your distal insertion of the MCL, and it actually blocks your pes anserin, causing a pseudo-locking. So one of the cause of pseudo-locking is the sternal lesion, but I've never seen one in the MCL. But they describe it sternal lesion. Okay, and then if you have MCL injury, you have to look hard for this POL. The grading is almost the same with the MCL. So what you want to look for is you want to look at the axial view and also coronal view. So in axial view, the first thing that you have to identify is your PCL and your SMCL, superficial MCL. So in between this area, this is called PMC, posterior-medial corner structure. So you can see that if you scroll, after this I will scroll one of the MRI for you, and you can see this is the POL, and it blends in with your joint capsule, and then the joint capsule blends in with the oblique popliteal ligament in front of the semimembranosus. So again, this is your semimembranosus, this is your PCL, this is your SMCL, and this area is your oblique POL, posterior oblique ligament, and this is your joint capsule. Oblique popliteal ligament is very difficult to see because it is very thin structure, and this is your semimembranosus. So you have to look for PCL, SMCL, semi-M, and in front of it is the this one, POL. So again, this is your PCL, SMCL. So you will see a fine structure here, black color, but you cannot see, and you can see that there is a high intensity signal suggesting that there is injury to your POL and also your posterior capsule, and this is your semimembranosus. Okay, again, this is your PCL, SMCL, this is your POL, and this is your joint capsule, and this is your semimembranosus. Okay, so this is the meniscus. So this is how you find the posterior oblique ligament and joint capsule, posterior joint capsule. The grading is the same. Management, okay. Based on literature, grade 1 and grade 2 test has a good prognosis if we treated conservatively. LAC actually found out that 98% success rate with non-operative protocol with RTP 3 to 8 weeks, and they actually use cast. They cast it in extension.
8 weeks.
No, they cast it for 1 to 2 weeks. Okay. Dashat and Garrick use knee brace, and the RTP is quite fast. Within 3 weeks, they can actually perform RTP already. However, grade 3 MCL tear is still controversial. Feto and Marshall actually look into MCL study. So they actually look into these 265 MCL injuries, and they actually have a thinking that all MCL injuries grade 3 need to perform operation. So they want to look into the success rate of the MCL reconstruction. However, there are some patients who are contraindicated. For example, they have skin infection, they refuse surgery, so they act as a control group. And in this study, they found out that the operative intervention and conservative has no improved outcome, meaning the outcome is the same. So they found out that there is benefit of the conservative management as compared to surgical, because surgical they have a lot of complication. So in Delicato actually look into the conservative management of MCL, and they found out that the conservative management have 90% success rate compared to non-surgical management 88%. And if they actually treat with early mobilization, they can actually have a better return to play as compared to if you immobilize. So this is actually a landmark study that shows that conservative management of grade 3 MCL could be one of the options instead of surgical management. So in mild MCL tear, we opted for conservative management. Ideally, we would like to protect the MCL using hinge knee brace, but some of the authors say that if you don't protect also is okay. But the most important thing is in the acute phase or acute inflammation is to reduce the swelling through ice, compression, elevation, isometric quads and hamstring and gluteal calf for strengthening, and we do PRM exercises as tolerated. As we are facing phase 2, which is your proliferative phase, we start to stimulate the healing by giving some heat therapy, electromodalities. We still protect the MCL using hinge knee brace, and we progress the strengthening flexibility, as well as start patient on proprioception and cardiorespiratory endurance. In phase 3, the maturation phase, we try to off brace and we progress the strengthening using as early as 3 weeks. In phase 4, the brace is off already and we start a sport specific and return to play. So the RTP for mild MCL tear is around 3 to 6 weeks. For severe MCL, it is still controversial, but there is a conservative protocol for severe MCL. However, the protocol is quite long. At the acute phase, it is up to 4 weeks where we protect the MCL using functional brace. Initially at 30 degree, and every 3 weeks or every 2 weeks we will actually progress to 90 degree. So 30 to 90. We allow no weight bearing or tiptoe weight bearing or partial weight bearing. Strengthening, we start with patient with isometric and flexibility. It is limited to 30 degree at the first 2 weeks, and then we progress to 90 degree up to 4 weeks.
That means we don't allow full extension.
Not allowed because POL is taught in the extension, so we want to relax the POL so that it can actually heal as well. So phase 2, similar, but the duration is longer, 4 to 6 weeks. We still actually protect using hinge knee brace instead of functional brace. And in phase 3, we start the patient on agility drill and allow return to running as early as 10 weeks. And in phase 4, we can actually try off hinge knee brace, but some of the authors actually recommend to use hinge knee brace for a few months. Start the patient on strengthening and also sport specific. This is the hinge knee brace. It's a functional brace, kan?
Yeah.
Orthopedic school of thought, they usually lock the knee in extension or put a cast, but that is wrong because there is a risk of arthrofibrosis. So we want to tackle the range of motion as early as possible, but not disturbing the healing of the MCL. And some of the surgeons prefer no weight bearing or protected weight bearing, but we can actually start tiptoe weight bearing. So this is by Miller's textbook, Sport Medicine and Orthopedic. So when you have MCL, examine, and if you find it is grade 1 or grade 2, you actually perform rehabilitation. If you have grade 3, then you have to make sure whether the patient has ACL or not. If ACL, then we aim for ACL reconstruction. If the MCL is unstable, for example, if they have the POL as well, so you need to perform MCL reconstruction. Otherwise, if the patient is quite stable with the MCL, then you can actually go for rehabilitation. So surgical option, they have direct repair with augmentation and anatomic reconstruction. So what they do, this is a 4-tunnel approach. So they have this femoral tunnel and tibial tunnel. They use allograft or autograft. So they tie here, and then they tie at the semimembranosus. Okay, this is the proximal attachment. This is the distal attachment. POL, quite oblique, and they attach to the semimembranosus as well. So this is the other technique. You can actually reconstruct your MCL, or you can use one single femoral tunnel or 2 femoral tunnel or 4 tunnel lah kita panggil. Post-operative principle is similar to the severe MCL rehab. And what about ACL with MCL tear? Let's look into the evidence. So Feto is the sports surgeon, so he has interest in MCL, so he performed a research on surgical reconstruction and repair of both ligament, ACL and MCL, and they found out that there is 79% unsatisfactory outcome because of the arthrofibrosis. So other surgeons look into ACL reconstruction alone. MCL, they say conservative. They have good outcome in the shell bone, Noyes, and also when Halin compare ACL recon with ACL plus MCL recon, similar outcome. So why hassle doing both reconstruction where you can live easily, kan? So they prefer ACL recon lah. Another thing, Halston and Barrett actually look into what if they perform MCL recon only. ACL, they treat conservative. Also good outcome, but they need to reconstruct MCL and POL. So they need to perform 2 reconstruction lah. So most of the surgeon, they actually comfortable with ACL recon and treat conservative to MCL. MCL recon and ACL recon rehab. Okay, first the range of motion is quite slow because you need 30 degree, 60 degree, 90 degree. Okay, but after 8 to 10 weeks, you are going to follow the ACL reconstruction rehab, almost similar. Return to play is almost the same for ACL. You need full RM, no instability, muscle strength is good, good proprioception, no tenderness over the MCL and no effusion. So this is my last slide, half an hour. So the key message is MCL is an important ligament, so treat it properly. If you need to put the brace, especially grade 3 MCL. When MCL is diagnosed, please rule out PMC as well, because the reasons for instability kadang-kadang is not your MCL but is your POL as well. So sometimes they might need surgical intervention where MCL and POL reconstruction is needed. So with that, thank you very much. I open for discussion.
Anybody got any comment? I myself tend to stick with the I think so far I've not seen a situation where MCL tear complicating the outcome of ACL reconstruction following the rehabilitation. So far I have not seen. Long-standing pain remains, that is an issue, but in terms of instability and return to play post ACL recon has not, MCL tear has not been an issue for me lah. So I think I'd stick with conservative management. But then again, it very much depends on surgeon preference lah. If they feel that they would like to reconstruct, then it's them.
So post you have mentioned the long-standing pain, right? So is it because the MCL tear or because other things?
Because of various other reasons. But some of the patients do present with pain in the medial aspect of the. For example, one of my patients who complained yesterday, he said he's still having pain in the medial side. Is it normal? Right? So could be. But the place where he pointed out to me looked pretty much like the MCL. His trauma was about 1.5 years ago. He already started playing football. So he showed it to me yesterday. So there could be a possibility of MCL insult into the tissue, but we are treating conservatively. But personally, I've only come across one situation where the MCL was repaired by the surgeon. One situation where one player, he was a former player, he came along with one paso, our DJ. They were in the same batch. So this guy was riding a motorbike. He hit a dog and he fell down. He tore his ACL, PCL, MCL, and they were all reconstructed. But the outcome was now he's no longer a football player. He's doing some other job. He couldn't return to play. So I do not know how much would construction of the MCL be useful as far as return to play protocol is concerned. Whether or not it is going to be earlier, or how much more effective can the person or player be in the field of play or day-to-day activity. Because if it is day-to-day activity, in my opinion, I think that MCL recon or not, it doesn't really matter lah. That is my opinion. Maybe somebody has a different take on the matter. Anybody?
I pun tak pernah encounter, but except one case yang Mr. Razif, I think few months ago dia ada buat reconstruction Antilik PCL and MCL. I don't remember one patient.
POL dah lupa tak?
Personally, I pernah encounter yang dia ada ACL dengan MCL at the same time, and then apparently the sport physician lah suggested treat the MCL first, then it heals, and then after that go for ACL.
Yeah. Itu pun ada encounter. Basically, kalau acute injury, when there is a MCL involvement, okay, based on your reading, if comparing ACL primary repair dengan MCL reconstruction, what's the difference in terms of time frame?
repair tu the problem. Kalau repair,
Repair, reconstruction.
kalau repair not many people do it because integrity of the ligament tu kan. Tapi in terms of statistical analysis tak sure.
I'm not exactly one the surgeon mention lah. Kalau fresh injury less than 6 weeks, they go for repair.
Repair.
Repair. And longer than that, no point in repairing, maybe record later. But whether do in one stage ataupun two stage, that depends on surgeon. Surgeon preference.
Tapi kalau acute risk of arthrofibrosis is quite high lah.
Correct.
So kalau macam dia, let's say kalau dia acute MCL dengan ACL kan, jadi kalau kau repair, that time kau mau repair ACL, tapi MCL tu macam kau repair, will it affect yang posterior?
Itulah dia kata based on the
Sama je lah.
study dekat ni, kalau you non-operated MCL, they have a good outcome. So,
repair MCL is better. Very good.
kalau you choose to repair MCL, also good outcome. If you choose to repair ACL alone pun good outcome juga. Tapi which one is easier? ACL lah kan. ACL
Because I think this one is a little bit skewed lah, because it must pretty much depend on what the patient's activity is. Because if you repair the MCL alone and you don't leave the ACL,
Stability.
stability is an issue. So I wouldn't really.
What's the outcome measure?
Yes. No, I think generally you are looking at patients' day-to-day activity.